welcome you all for the first session. The title of my talk is, and actually Dr. Amit has given great introduction, so many things I don't need to go in detail. And Dr. Amit, I hope you can see the data, and we can of course discuss more on the numbers. That's a never-ending game, I must say. So the title of the talk is prognostication of hormone positive HER2 negative early stage breast cancer patients in India, and where is Canas's breast in this? So just agenda of the talk today is I'll give an introduction to Canas's breast, go through the data, India versus Caucasian data, impact of age, node, chemotherapy on Canas's breast, CAP-based risk stratification, clinically low risk patients, chemotherapy benefit, and how does Canas's breast compare with Oncotype Ki67 and Luminal AB? And it's been Canas's been breast has been used in India. So how is it helping patients? How is it impacting patients? I think all of you know this, that eighth edition of HSCC has changed the way staging is done for early breast cancers, and prognostication is increasingly considered important aspect in staging the patient. And it's not just purely anatomy based. There are also prognostic group based on multi-gene panels has been added to stage the disease, and hence because it does help to customize patients' treatment to a large extent, and these become the prognostic tests have become mainstream in many countries. However, ICMR guidelines don't include the Western prognostic tests such as Oncotype, MammaPrint, and Prosigna, etc., in ICMR's guidelines for breast cancer disease management. And that is primarily because these tests are not well validated on Indian patients who can be different. And why is that important? Because our patients, as I think Dr. Amit also alluded to, are younger. They come at a younger age. They have a bigger tumor burden, and they come typically at symptomatic stage 2 disease, as against the Western patients who are elderly. I mean, compared to our patients, they have smaller tumors, screen detected, and so on. So we felt back in 2011, I felt that the unmet need is really to have a test that is developed on our patients who are younger at onset, who come with a heavy tumor burden. I really felt that was the unmet need, and hence we started the march for developing Canas's breast, which would really be indicative, representative of Indian/Asian patients. So, what is Canas's breast? It's an immunohistochemistry based test in which we look at expression patterns of 5 key proteins which are involved in really spreading the disease from the duct to elsewhere. And immunohistochemistry is performed for those 5 biomarkers on a Roche's Ventana automated platform. They are graded quantitatively, and that information, along with the patient's tumor size, grade, and node status, gets into our artificial intelligence based algorithm, which uses machine learning methods. And we get a Canas's breast risk score, which is a numerical number between 0 and 100, and a patient with a cutoff with a risk score of 15.5 is considered as low risk for 15.5 or lower is considered to be low risk for cancer recurrence, and the patients above that are considered high risk for cancer recurrence, and the treatment can be planned based on this. I must say, I must make highlight here that this was primarily developed on Indian patients. About 95% patients are Indian patients. And so everyone is curious. Most people ask me, are your 5 biomarkers CRP or HER2? The answer is no. We go beyond proliferation and hormonal indices. We realize the importance ERP or HER2 bring in, but those are done routinely, and therefore we don't want to include them in the test again. So what we really look at is how does the cancer cell in the tumor in the duct spread out into the liver or lung or bone. So it goes through multiple steps, and the critical steps are EMT, the losing, coming out of this tumor cell, losing adhesion, invading the blood vessels, again going through MET, and then building the chemoresistance to initiate a new tumor at a hostile site, another hostile site. So we looked at multiple, more than 40 biomarkers, and we finally narrowed down the statistical model on these 5 biomarkers, which play absolutely critical roles in these 3 critical steps involved in the cancer progression from duct to elsewhere in the body. And so Ganas's breast uses these 5 biomarkers, and these are the representative pictures of immunohistochemistry. Now, any Canna's list falls in the group of lab developed test, and it has really undergone rigorous development and rigorous validation over 9 years to come to this stage. So we have showcased analytical validity of this test, which is essentially reproducibility and repeatability of this test, and this data is published in BMC Cancer. Clinical validity is really, proof lies in this, is, you developed it on a set of patients, on an absolutely independent set of patients. How does the test work? How accurately? What's the NPV? So we have so far validated Canis in India, US, Spain, Austria, Italy, and studies are underway in Germany, Netherlands, and US again. And clinical validity is prospective use of this test and in the clinical setting. And so far we have used it on 850 plus patients, and I'll showcase you brief data on that. We have done some interim analysis so far. Now, coming to clinical validation of the test, as I mentioned, these are the absolutely wonderful hospitals and the clinicians who have worked with us. Many of you are here listening to me. Many of you spoke with me right in 2011, trying to work with me on the test. So really appreciate all your help and efforts to come up to this stage. We have validated also in India and with at all of these sites across the world. Now coming to Canas's breast based risk stratification. So how does it do? So this is the total cohort. Canas's breast generates two actionable risk group. There is no intermediate risk group. This Kaplan-Meier curve on the left shows the total cohort of 1767 patients till date. And Canas's breast is able to segregate the low risk from high risk in a very statistically significant manner with a good distance metastasis-free survival for the low risk patients. This is the total cohort. All patients were given chemotherapy and endocrine therapy. So everybody, I'm sure, wonders about how would the test outcome look if you were to use only endocrine therapy alone treated patient cohort. So we did a group analysis, and the Kaplan-Meier graph on the right shows, yes, Canis best is able to segregate patients into low and high risk, even in endocrine therapy alone treated patients, indicating it is the chemotherapy does not play a role in stratification by Canis's breast, and the test is able to segregate patients well with a high NPV in both sets of patients. Now this is now coming to the cohort details, demographic details. So Indian patients are 925 amongst the total cohort, and the rest are Caucasians. So as you can imagine, there are differences between Indians and Caucasians, and I would like to highlight them in this table here. So we do have at under 50, we have more than the Caucasians. They have more over 50. They have more T1 patients. We have more T2 patients. They have more node negative patients. We have more N1 patients. And really importantly, we have more grade 3 patients. Grade 2 was the most common dominant across the two sets, but grade 3, we had a lot more than them. And they had a lot more patients who received only endocrine therapy as against our patients who 80% of them received chemoendocrine therapy. So given that we have this such differences in the populations, the question now comes to our mind is, is Canis able to segregate both sets of patients equally well into low and high risk patients? So I'm going to showcase the data in the next few slides based about the two different populations separately. So the first is the Indian subcohort. This is the data on total cohort, which is chemoendocrine treated, based patients treated with both, and patients treated with endocrine therapy alone. As you can see, Canis best is able to segregate both sets of patients in a statistically significant manner with a high NPV. Next is under 50 and over 50. Once again, Canis best is able to segregate both of them, indicating it can be used across age groups. And the third is the node negative and the node positive patients. We do often get patients in with one node positive disease, and hence our goal was to really showcase that all of the patients that you encounter in clinic today are indeed, we have validated the test Canis breast on, and once again, node negative and node positive patients, we were able to segregate using Canis breast equally well in a statistically significant manner. Now moving on to Caucasian subcohort. So as you can see, once again, chemoendocrine and endocrine therapy alone patients were segregated. And Canis best was able to segregate both sets of patients equally well with a statistically significant, in a statistically significant manner. Then next question was really about the age, and yes, once again, under 50 and over 50 patients, if you were to Caucasian subcohort, if you were to look at how is Canas's list able to segregate them, it is indeed able to segregate both sets of patients well in a statistically significant manner. And last slide on the Caucasian subgroup is node negative and node positive patients. We were Canis best is able to segregate both sets of patients into low and high risk subgroups equally well. The next slide, slide number 22, shows Canas's best in a multivariate analysis that Canas's best risk score is indeed an independent predictor of prognosis. Along with the Canas's best risk score, we also looked at age, node, and the stage of the disease in separately in Indian cohort and in Caucasian cohort. And you can see that Canas's best risk score had the highest hazard ratio and in a very statistically significant p-value, indicating it is indeed an independent predictor of prognosis. And we did not include ERP or HER2 since the test is meant for them. Now, coming to the chemotherapy benefit aspect. So I think Oncotype DX has shown this in the previous retrospective validation quite well. So I would like to really bring your attention to this, the Kaplan-Meier graph on the left. As you can see, if you look at all the patients stratified as low risk for cancer recurrence, uh, stratified by Canas's best as low risk for cancer recurrence, and the blue line is chemoendocrine, red line is endocrine therapy alone. Both the graphs are overlapping, indicating when the patient is stratified as low risk for cancer recurrence, she does not benefit from adding chemotherapy to the regime. On the contrary, if you look at the right side Kaplan-Meier graph, which is for all the patients stratified as high risk for cancer recurrence, um, using Canas's breast test, the endocrine therapy treated patients alone tend to recur often. And if you add chemotherapy to the regime, there is a benefit in the distant metastasis free survival to these patients, indicating only the high risk patients are benefiting from chemotherapy as per Canas's breast based segregation. Now the slide 24 shows you, which is again, once again, we get this question quite often, how does Canas's best segregate the clinically low risk patients? And these are really the patients you would encounter in the clinic, T1 node negative patients, and then how do you treat this patient? So the total cohort consists of these two and some of the T3 N0s as well. So this is the total cohort, and Canas's best is able to segregate the low risk from high risk very well. And I just want to make a mental note that all of these are endocrine therapy treated patients alone. And when we looked at T1 N0 patients, which are really clinically low risk, there was a 8% patient, Canas's best was able to segregate 8% patients who were considered, who were stratified as high risk for cancer recurrence. And in T1 T2 node negative patients, we were able to segregate again low and high risk for cancer recurrence with a really good NPV, even in T1, in the T2 disease patients. 89% and 96% NPV, and about 11% patients were stratified as high risk for cancer recurrence, and they did indeed have higher recurrence rates. So this goes to show that Canas's best is able to carve out the high risk patients even out of the low risk, even out of the clinically low risk patients. And this really once again stresses the fact that we go beyond the anatomy, we go beyond ERP or HER2 status. We really look at the tumor biology in detail, and hence we are able to find out these patients who are at high risk for cancer recurrence amongst the clinically low risk patients. Now, why is all of this important? I think all of you must have seen the ESMO presentation in the JCO paper by Stephen Johnson on use of CDK4/6 inhibitor in the high risk early stage hormone positive HER2 negative early breast cancers. So the monarchy study showed very conclusively that there is a 25% increase in invasive disease-free survival of patients of patients clinically considered to be high risk for cancer recurrence. And this is entirely based on clinical criteria. These were the criteria used: a 5,000 patient trial, 5,800 patient trial, I think. And they were able to show that patients who received abemaciclib, where they had a 25% increase in invasive disease-free survival and at a 3.5% increase in invasive disease-free survival. So this shows that if you know the patient is high risk for cancer recurrence, you can treat her differently, and you can give her the CDK4/6 inhibitors. What is interesting here is we try to analyze how would this population look out of our existing cohort. So we looked at this, we segregated patients, this entire patient cohort is using these criterias. And you can see that Canasys was able to segregate about 56% of this cohort, the clinically high risk cohort, into low and high risk. And we believe perhaps the low risk patients may not benefit from addition of CDK4/6 inhibitors, since the arm, placebo arm, that is without the abemaciclib arm, had about similar survival as Canasys based low risk patients. Of course, we need to, this is just our analysis, but it is interesting to see that it is important to segregate patients. Patient selection for any drug is really critical, and perhaps use of prognostic tests like these, Canasys based and other tests, can certainly be helpful in identifying the real high risk patients out of the clinically high risk patients beyond anatomy based on biology, and only treat these patients with the CDK4/6 inhibitor. It's in an adjuvant setting. Now, coming to the final aspect of the presentation, which is comparison with other prognostic tests and the biomarkers. So we first, I would like to compare. I would like to showcase data of Canasys compared with Oncotype DX. This was published
Dr.
in.
Manjiri, 3 minutes left.
Sure. Okay. This was submitted in ASCO and recently got accepted in cancer medicine. So Canasys BEST and Oncotype, this is a head-to-head trial on the same samples. 83% was stratified as low risk by CAB and 90% by Oncotype DX. And what is the take-home lesson in this and complicated slide is both of us have, both the tests, Canasys BEST and Oncotype, have 83% concordance on the low risk stratification. That is, both the tests call the same 83% patient low risk, and the patients are doing well. So because this is retrospective, we have the follow-ups. And another important aspect is the intermediate risk zone, although this is now disappeared because now we have a Taylor X cutoff. But out of the intermediate risk patients, since the trial was done on those older cutoffs, we looked at the majority of the intermediate, about 85% of them were certified as low risk by Canasys BEST. I'm not in the intercept, I'm not going through mama print data, but we have similar concordance, about 83%. And remember, at Optima Brilliant trial, no two tests had more than 60% concordance. So this we found quite interesting. If you were to compare with Key67 based certification, the difference in DMFS is not much compared to Canasys based, irrespective of the cutoff use. And this is not even statistically significant. So Canasys based is doing a better job than Key67. With respect to luminal AB certification, yes, once again, luminal A's are only 31%, whereas CAB is able to find low risk patients of 75%. And finally, I
Dr.
will,
Manjiri, 1 minute left.
showcase you how is Canasys BEST impacting treatment in India today. It has been in use for last about 3 years. So far, more than 250 clinicians across 30 cities in India have used it on 850 plus patients, and we have found 67% low risk and 91% adherence to Canasys BEST risk stratification. That is, they were spared of chemotherapy based on our thing, and 64% patients have avoided chemotherapy. So to summarize, Canasys BEST is indeed a robust test which is cost-effective, immunohistochemistry-based prognostic sets. It is independent of age, grade, chemotherapy, and chemotherapy benefit is seen in high-risk patients only. It has good concordance with Oncotype, MammaPrint, and other commonly used methods like Key67, luminal AB. ISC4 data also I couldn't go through in the interest of time. And we've been in clinical use, and it has certainly saved 64% of the patients from chemotherapy. So why Canasys BEST? Because it is developed and validated on Indian patients. It has all the regulatory approvals, patent protected, and our publications are listed here, and we'll be happy to send them to you should you need them. Thank you very much for listening to me.